Hi guys, this is Dr. Volshteyn, and I wanted to create this video to explain how to take care of the patients with lipedema after the surgery. So first, let me explain you what we do. The patients with lipedema have a lot of pain, and the pain is located in the legs or the arms. We usually treat the arms and legs separately. As a matter of fact, usually when I do the surgeries on the legs, I divide them into two. I treat either the front or the back. So what I treat is usually the front of the legs, outside of the legs, inside of the legs on both sides. And I do not treat the back at the same time. The reason I do it this way is so that there's a better lymphatic drainage, because all these patients with lipedema have a problem with lymphatic drainage. 3 months later, the patients come in, and then we do the back of the legs, the insides and outsides, both sides. And then 3 months later, we do the arms. So that's how the process works. So during the surgery, what we do, we put a large volume of fluid that contains saline, epinephrine, lidocaine, and bicarb. Saline is to break the fat cells loose. Lidocaine is to numb up the tissues during the surgery. Epinephrine to shrink the blood vessels. And the bicarbonate to make sure the whole mixture works a little faster and a little better. So usually we put between 6 to 10 liters of that fluid into the legs, a little bit less in the arms. We give it about 30 to 40 minutes, and then I start suctioning. Now, you probably know that there are 2 layers of fat. There is a skin and superficial fascia, this is called superficial fat, and there is a superficial fascia and muscle, that's a bottom layer of the fat. So separate, upper fat, lower fat, or superficial fat, deep fat. So majority of the fat that is removed from the deep layer of the fat, because that's where majority of the lipedema nodules are. And then we do a little bit on the surface too to contour it. So you can imagine that this is the skin and this is the muscle and the fascia is in the middle. Now all those spaces became semi-empty, and we're trying to get them to collapse or come together so it can heal. Now, because we remove such a large amount of fluids, what happens is that the body goes through the fluid shifts and through extensive healing process. So let's start one step at a time, going through each one of those aspects as it relates to the nursing care, okay? So after the surgery, most patients will have a special garment which looks like a stocking starting on the feet, starting from the mid-foot all the way up to the groin. So from the foot all the way to the groin, and sometimes even to the waistline. Now, that garment may or may not fit well because sometimes people use it twice. But the goal of the garment is to provide very gentle compression, as well as provide the base layer for a stronger compression on top. So this is just to create the baseline. Now, on top of this garment that patient provides, they're going to have either ACE wraps or short stretch bandages that are used for lymphedema, or they're going to have a Velcro-based compression wraps, okay? Remember that fluid that we put in? That fluid can get out of the body in 2 ways. One is it can leak out, and the second, it can go through the kidneys and get filtered by the kidneys. So we prefer to have it leak out through the skin. And the reason we like it is because it doesn't overload the kidneys. And this fluid will leak out usually for the first 24 to 36 hours. And at that point, most of the little openings will close off. Sometimes 1 or 2 openings can drain for about a week or 2, and that's okay, all right? The incisions that I make, they're about this big, I would say about 4 to 5 millimeters. We do not put stitches in them. And the reason we don't, because we want the fluid to come out, because it provides faster healing. Now, the way the nurses in the operating room dress this is that, remember that garment underneath? We make holes in it. And through those holes, we put ABD pads over the incisions. And the location of the incisions is pretty standard. So if this is a leg, I go above the ankle, below the knee, above the knee, and in the groin, and sometimes on the side of the hip. So it's 1, 2, 3, 4, 5, 6, 7, 8, 9. There's 9 incisions per leg. On the back, it's about the same. So you will see the slide, so the garment cut right here, right here, right here, and right there, maybe on the side, so that we can put ABD pad over the both incisions, and they continue to drain. A very important thing is that whenever the area stops draining, we need to remove the dry ABD pad, because if you don't, what happens is it hardens up from the body sweat, and then it creates an imprint on the skin, creating an indentation. That's really what we're trying to avoid. So once the wound stops draining, take the ABD pad out, okay? Now, the ABD pads are usually initially placed every 4 hours to absorb the fluid, or as much as possible. And then once the drainage decreases, you can slowly do it every shift, every 12 hours, every day, just pretty much as needed. Now, the way to do it is you basically unvelcro the compression wraps. Then you have exposed underneath garment with slits in it. Take the ABD pads out, and then lift the garment up and put a new ABD pad underneath and Velcro it back. Now, the Velcro should be reasonably snug, okay? It's very important. It needs to be snug, but not too tight. If we use Velcro wraps, we're gonna have 4 pieces of Velcro wraps. One is gonna be on the foot, one is gonna be on the lower leg, one is gonna be on the knee, and the final 4th one is gonna be on the thigh, extending into the hip. The problem with those is if they're too loose, they're gonna fall down. If they're too tight, they're gonna choke off the blood supply. And sometimes it's hard to figure out how tight to make them. So ask the patient what feels better. And usually they will tell you a little tighter, a little looser, and sometimes it'll change. But listen to the body knows what it's doing. Sometimes you may notice that the feet are swelling up. So either your foot compression is too loose, or your lower leg compression is too tight, causing almost like a tourniquet effect. So you have to play around with that a little bit, okay? So now, return back. You have the garment underneath, slits in the garment, ABD pads underneath the garment through those slits, and Velcro on top. Now, if patient does not pay for Velcro garment, usually we put or ask him to put ACE wrap, and then you kind of have to un-ACE the leg, change the dressing, and then put the ACE back on. The reason we started putting the garment underneath is because ACE wrap was our first approach, and what we noticed is if you put it on top of the skin directly, the ACE wrap would rope up and then create indentations. So that's why we started doing a double layer. Okay. Now, the purpose of this strong double compression is to control the swelling, limit the drainage, and facilitate the recovery. If you take all of it off, patient says, oh, it's too hard, I don't want to do it, it feels bad. What's going to happen is that all that swelling is going to go into the legs, and they're going to have a lot of third spacing. So they'll be really swelling in the legs, but they'll actually be dehydrated inside of their blood vessels. It's kind of almost a parody there. So in order for the patient to heal faster and to push all the fluid back into the circulation, that's why you need those compression. And a little bit of elevation also helps, okay? The issue is not as bad with upper extremities because they're located higher. The problem is usually with the lower extremities. Now, for the first week, we do not want the patient to take those garments completely off, especially the underlying garment. And the reason why we don't want it is because, remember, we removed all the fat from underneath. Now there's a lot of mobility there. When you start pulling the garment off, you can have what's called a shear injury. So the tissues will shift like this as somebody's pulling the garment. And those tiny little blood vessels that are forming in between the tissues trying to heal the layers together, they'll tear up, and now you have a big bleeding underneath, having a fairly large size hematoma. Very difficult to deal with because I have to then aspirate it, suction it, and it provides a very prolonged swelling for months and months on. So I would strongly encourage you not to remove the garment for the first week. I mean, if it stinks, and sometimes it does actually, you can take the Velcro off, throw it in a washing machine, wash it, give the patient a hair dryer. They can dry up the garment, and I do get it. It's gross, but that's the safest way to do it. And then they kind of body wash with a towel on top. They cannot take a shower yet. At the weak point, they're going to come back to our office, and if they're good, they'll be allowed to take a shower. All right. If you're going to wash the compression wrap, you can just put in washer, dryer, and put it back on. Don't keep it too long, and make sure the legs are elevated because they're going to swell up really quickly. You will also notice is when they're off, the patient will feel dizzy and lightheaded. Okay. The patients with lipedema also have a risk of having a POTS syndrome, which is postural orthostatic hypotension. And it's usually a delayed phenomenon. So think about it this way. The patient stands up, right? The blood and swelling pulls in the legs, and then there's not enough blood in the bloodstream, and they feel lightheaded. Usually the body would compensate by creating increased heart rate, tachycardia. But in the patient's lipedema, opposite happens. Their blood pressure drops and their heart rate drops, and they pass out. And it also doesn't happen right away. It happens about 5 to 10 minutes out. Or especially when they strain, when they go in the bathroom, try to poop, and then they strain, blood pressure drops, heart rate drops, and then they plop on the side. So our recommendation is be really slow getting the patients up. Get them to sit on the edge of the bed for a few minutes. Get the nurse to be nearby. If they stand up, get the nurse to be nearby. If they go to the bathroom, until you're comfortable that the patient is not lightheaded, have somebody nearby so they can call for help. All right. And it usually gets better. At about a week after the surgery, if a patient needs to be really hydrated, remember to avoid the hypotension. So we don't put too much fluid in, but sometimes they need a little bolus within the first week. And I let your medical director determine that based on their urine output. The medications that they're usually on are, they're on Xarelto, 2.5 milligrams twice a day to prevent blood clots. They're on Keflex, 500 milligrams 4 times a day to prevent infection. If they're allergic to Keflex, we'll recommend either Bactrim or erythromycin or clindamycin, whatever they prefer. On top of it, they're on gabapentin, usually about 300 milligrams once a day or twice a day because they have a lot of nerve pain from original condition and then especially after the surgery. We also put them on either Celebrex, 200 milligrams twice a day, or Mobic, 15 milligrams once a day as a non-steroidal anti-inflammatory. And then on top of it, we put them on Percocet if necessary. Also, we find that scopolamine patch usually helps to improve the effect of medications. And sometimes they have nausea, so we give them an option for Zofran, either sublingual tablet or otherwise. Usually, we don't want to do any manual lymphatic massage or any kind of compression for the first week because it'll actually, remember, shear the tissues. We don't want that. We want a good, strong compression that the patient will actually like. They'll really feel comfortable with the compression, and a significant portion of the pain will be gone. If we do liposuction above the hip area, like on the lower back, on the upper hips, on the lower abdomen, the garment is really not compressing that. So usually we put the patient in the abdominal binder, and that kind of helps to compress it. Sometimes the patients have pain on the back. So if we're doing the back and we go above the buttocks, because that's where lipedema is also, the abdominal binder doesn't provide enough compression, and patients commonly complain, my back hurts, my back hurts. And even medications don't help very much. So one of the best things we found to do is take a towel, roll it up, basically like a back roll, put it underneath the back, right above their buttocks, and they lay on it, and that pressure is really soothing for the pain, okay? And finally, some of the patients experience muscle cramps because remember, we remove the fat from this space right above the muscle, and inadvertently we can scrape the muscle with liposuction cannula. So if they complain of muscle cramps, pain medication is not going to work very well. Gabapentin is not going to work very well. What works is a low dose Valium. So usually for sedation, you give 5 to 10 milligrams. For muscle cramps, we give 2.5 milligrams, and it works like a charm. Okay. The same medication really works well after tummy tucks when we tighten the muscles and they feel that muscle cramp pain on the abdomen. Valium at low dose usually helps really well. So that's about dressings, and that's about medications. Nutrition-wise, I need the basic diet. Ideally high protein, ideally more of a Mediterranean, ideally with limited amount of carbs, mostly because they have usually insulin resistance issues, and that carb diet goes straight into their hips and actually counteracts the surgeries that we're trying to accomplish. A lot of times they don't have good appetite, so we kind of need to at least get them protein shakes to get them going with hydration. Otherwise, they'll be miserable and healing really slow. From the standpoint of activity, they need to be ambulating at least 3 times a day. And initially, it'll be a little bit tough. So get them in the chair, get them to stand up, maybe sit them up in the bed as a minimum. But we have to push them. They are very tired. And the reason they're tired because the area that we're working on is huge. I mean, from the ankle all the way to the hip. So it's a very large area. On one hand, we need to make sure they're hydrated and eating well. And at the same time, we're kind of push them a little bit so they can walk. And initially, they won't be able to walk much, but then they'll do better. One of the frustration comes when they stand up and all those Velcros start falling off. So one of the ways to combat that is take safety pins and pin the compression wrap, the Velcro wrap, to the underlying garment. So that's one of the ways. The other way is actually layer one on top of the other. So if you do the top one on the thigh first, then you got the knee one that overlaps the thigh, and then you got the lower leg that overlaps the knee one, and then the foot one that slightly overlaps on top of the lower leg, you know, those 4 pieces that's put on. This way, they kind of stabilize each other. But sometimes it's still very frustrating because a lot of these ladies have very like cone-shaped thighs and everything falls off. So you kind of have to MacGyver to an extent. Sometimes we found that people put abdominal binder and they connect the outer edge of the Velcro to the abdominal binder. So the abdominal binder actually holding them. Unfortunately, there's no great garments that are able to do it in a reliable fashion. And that's why we're kind of forced to use this. But it's been working well. It's definitely better than what other people do. Now, you probably notice that some of the doctors, especially in California, put drains. We did not find that the drains are very helpful. We found that this Velcro compression is actually better than that. And occasionally we still have a little seromas, but most of the time with compression, they go in their own. Our usual instructions in regard to compression is the patient has to wear it for 4 to 6 weeks. And usually they will self-limit. Sometimes they notice that whenever they wear compression, they feel better. And at some point, it kind of goes in reverse, where they wear compression, doesn't feel good at all. They take it off, they feel better. So at that point, they can stop wearing the heavier compression. But the routine is 4 to 6 weeks continuous compression, 24 hours a day. All right. When the garments are placed, sometimes the garment underneath will rub the skin and cause skin abrasions. Most common areas of the abrasions that we get is on the back, below the knee, on the upper portion of the posterior calf, on the front of the shin, and especially at the junction from the lower leg to the foot, like on the dorsum of the foot. And it has to do with the garment folding on top of it and causing the rubbing. So the solution is either to put a little ABD or some kind of soft pad underneath, or the other option is basically slice the garment there. You can slice it either on top or slice it on the side of it, just to make sure that it doesn't rub. But the patient will tell you, it's kind of feels like it's rubbing, and you can see a little redness. It's going to be a friction burn. Sometimes it's going to be superficial, sometimes it's going to be medium with a blister, and sometimes it could be full thickness. They usually heal, but if we can avoid them, that'll be great. And again, just ask the patient and see if there's redness. Again, if there's redness, pat it or split the garment for a short distance, okay? The garment will have a tendency of sliding down. So the garments usually have a split in the middle. So when the patient sits down to do number 1 and number 2, they're separated. And a lot of patients do well with it, but sometimes it's kind of hard to pull the garment up. By the way, when you put the garment up, you cannot just jump it like you would do pantyhose. You have to actually stretch it and kind of pull it and then lay on the leg. Remember, we're trying to avoid that shear injury. So you usually position it. And the biggest problem we usually see is that the garment is too low. They're like this far or something like this below the area where it needs to be compressing the pubic area. So nurses will have to check on that, make sure that it needs to be adjusted. And the easiest way to adjust is get the patient to stand up and just kind of gently pull it up. And usually requires a couple of people. And the patient will tell you, hey, this is a good position. From a standpoint of urination, you usually keep the Foley catheter for the first 24 hours so the patient doesn't have to get up, and then we remove it. But sometimes the patients still have a hard time going to the bathroom with urination. So the wick usually works actually pretty well. Some patients like it, some patients hate it. But I kind of defer to your nursing experience to figure out what's the best way to do it. So I think pretty much it covers all the medications, all the wound care, and all the other things that you need to know. Oh, by the end of the first week, if the patient still stays with you after the surgery, patient may hit a psychological breakdown period. So what happens is we remove a lot of fat, but the patient has a certain level of estrogen in the system that is still attached to the amount of fat that used to be. So now you have significantly more free estrogen that's floating around, and the patient will be crying, emotional, depressed, all this wonderful stuff. And this is almost like they're kind of pregnant for a short period of time because of hormone disbalance between the amount of fat that they have now and the amount of estrogen that's floating. And the body will adjust within a couple of days. So we usually warn the patient that may happen. Usually happens on day number 9 to 10, but sometimes a little bit earlier. So just to be aware, just don't panic, don't have to overload them with antidepressants. They have to be usually encouraged, and the body will adjust it 99% of the time. Don't look at the oozing from the incisions as bleeding. They're not really bleeding out that much. But if you're concerned about bleeding, then they need to have CBC and chemistries checked. The transfusion benchmark is about hemoglobin of 7. Or if they have slightly higher hemoglobin and a higher level of tachycardia. But I defer to your medical doctors to do that. If you need any help or you have any concerns, please let us know. But really, most of the time, it's self-explanatory. Have a good communication with the patient. They'll guide you through it. Sometimes they know more about it, especially if it's that their second or third surgery, than a lot of nurses do. No offense. A lot of the patients are staying together through Facebook social groups, and they teach each other. Plus, we'll have other videos that were put together for education of the patients. So a lot of times they're kind of prepared for it and even challenge the nurses on their experience, which sometimes actually justifiable. So hopefully that helps. I know it's a long video, but the idea is so you're comfortable with the process and hopefully can avoid majority of problems that are associated with post-op care of lipedema patients. All right.